Welcome, and thank you for joining us today. My name is Janice Butchko. I am Assistant Director of Patient Care at the MDS Foundation, and joining me today is Ashley Moncrief, Director of Patient Care. We will be moderating today's webinar. Before we get started, I would like to provide a brief overview of the MDS Foundation. The MDS Foundation is a global nonprofit organization dedicated to supporting patients and caregivers affected by MDS, a group of rare and life-threatening bone marrow disorders and the healthcare professionals who are committed to caring for and ultimately curing these cancers. Since our founding more than 30 years ago, the MDS Foundation has remained steadfast in our mission to advance research, provide critical education and support services, and improve treatment options for those impacted by MDS. We have built a strong global network connecting patients, caregivers, and healthcare professionals with vital resources, education, and support. To name a few, here are some key resources that are available for you. Patient and family forums. We hold 6 across the U.S. every year. These programs provide an opportunity for patients and loved ones to connect with others going through the similar experience and learn more about MDS. These forums are led by an MDS Center of Excellence expert. We also hold an international patient forum every 2 years at our International Congress. This year, we held one in Rotterdam, the Netherlands, on May 10th. Webinars. We hold 4 virtual webinars a year on a variety of topics to enable patients and their caregivers access to questions of an expert and receive support information without having to travel. Disease-specific materials. We offer several valuable resources available via print or download for patients, caregivers, and healthcare professionals that provide comprehensive disease-specific information to help you have the information needed to make the most informed decisions for care. Clinical trial awareness. We also provide a clinical trial matching platform on our website and through our patient liaison. Share new clinical trial information with patients so you can always be informed about and access to the latest treatments. Support groups. We host in-person and virtual support groups around the world and encourage you to reach out or visit our website to learn more. MDS Exchange. The MDS Exchange is a dedicated online community where patients and caregivers can connect, share experiences, and support one another. It is easy to use and powered by cutting-edge technology that enables the MDS Foundation to enhance engagement, deliver deeper insights, and strengthen community connections. And finally, we host 4 Move for MDS walks across the country that are great opportunities to not only raise awareness of the disease, but to connect with others. This year, we hosted walks in Tampa on April 27th, Chicago on May 18th, and our upcoming walks are in New York City on September 14th, and our Boston virtual walk on October 19th. For more information and to access these resources, please visit the MDS Foundation website at www.mds-foundation.org. Today's webinar is being recorded, so it will be available for on-demand viewing on our website in 7 business days. The live question and answer segment with Dr. Kent will be available for all participants after Dr. Kent's pre-recorded presentation. You can submit your questions via the Q&A button on the bottom menu bar. I would like to give a special thank you to Taiho Oncology for supporting this webinar program. We will now begin with today's webinar entitled Stem Cell Transplants and Cell Therapies for MDS. Today's presenter is Dr. Andrew Kent, an associate professor in hematology oncology division at the University of Colorado. Dr. Kent completed his undergraduate degree in biology at the University of Chicago, his MD and PhD training at the Icahn School of Medicine at Mount Sinai in New York City, and his internal medicine residency in heme onc following training as part of the physician scientist training program at the University of Colorado. Aside from treating MDS and AML patients with particular focus on stem cell transplant, he is in active translational research and phase 1 clinical trials focused on developing new immunologic and cellular therapies for myeloid diseases. It is my pleasure to introduce Dr. Andrew Kent.
Pleasure to be here. All right. Well, hello, everyone. My name is Andrew Kent. I'm one of the assistant professors in the hematology and bone marrow transplant division at the University of Colorado. Today, I'm going to be talking about stem cell transplants and emerging cell therapies for myelodysplastic syndromes. So brief outline of the talk today. I'm going to give you a short history of stem cell transplants in general, and then I'm going to talk about our current clinical practice for stem cell transplants with a focus on how we do it for myelodysplastic syndromes. And then I'm going to touch briefly on future cell therapies. So transplants, unfortunately, had emerged from a very tragic part of human history around the time of World War II, with the development of nuclear weapons and our increasing understanding of radiation. It was noted that there was a lot of aplasia or bone marrow failure that occurred after lethal irradiation by atomic bombs. This naturally led to the question, can you replace a failing or sick bone marrow with a healthy one from somebody else? So there are two types of transplants. Autologous means you give your own cells back, and allogeneic means you get cells from somebody else to replenish your bone marrow. Obviously here, you'd want to take a healthy person's stem cells or bone marrow and replace them into the sick person. So we're going to be focusing on the effects of allogeneic transplants for this talk. I often get questions from patients, what's the difference between a stem cell transplant and a bone marrow transplant? Essentially, the result is the same thing. You have hematopoietic stem cells that live in your bone marrow your entire life. You're born with them. Throughout your entire life, they produce all your blood and immune cells. And when you get something like myelodysplastic syndrome, we think it's those stem cells in your bone marrow that are not functioning properly. So historically, it was thought that you had to actually extract the cells, the stem cells, from the healthy bone marrow of some donor. Nowadays, with modern medicine, specifically something called GCSF, or granulocyte colony stimulating factor, this medicine can trigger the stem cells to actually leave the bone marrow and go into the bloodstream. So here, this is the bone marrow, and this is a blood vessel near the bone marrow. When you give GCSF, these hematopoietic stem and progenitor cells are triggered to sneak into the bloodstream. And so the donor just takes this medicine for 5 days, and then you're able to collect the stem cells that emerge from the bone marrow by simply doing a blood donation procedure. So again, the result of a bone marrow or stem cell transplant are the same thing. You're isolating those stem cells from the bone marrow. It's really just the source of those stem cells being either from blood or from the bone marrow itself. Nowadays, because isolating from blood is much easier and much less of an event for the donor, that's by far and large the most common way that we harvest the stem cells from the donor. Early clinical studies for transplants were done in the 1950s to 60s. Over this 10-year period from 1957 to 1967, over 200 patients received bone marrow transplants after lethal irradiation. The first transplants were done by a doctor named Dr. Thomas, who published his first experience in 1957 in the New England Journal of Medicine. These 200 patients received bone marrow transplants for a variety of reasons. 73 for aplastic anemia, 115 for hematologic malignancies, which could include myelodysplastic syndrome, and 12 for immunodeficiency. What do you think the outcomes were for those first 100 patients? Unfortunately, all of them did not survive the procedure. 125 of them had graft failure, means the donor cells did not take in the recipient. 47 of them developed graft versus host disease, which we'll talk about in a minute. And 28 of them had infections or their disease relapsed. So really a rough start for transplants. This laid the foundation and provided a lot of basic understanding for why they didn't work, and helped us develop and improve upon them, such that our outcomes are much better today. This is E. Donald Thomas. He won the Nobel Prize for his foundational work in 1990. Despite this rough beginning, he persevered and really laid the foundation for all that we do with transplants today. So one of the reasons all these transplants failed in the beginning was because we didn't understand what the HLA system was. HLA stands for human leukocyte antigens. It's also called the major histocompatibility complex in humans. Essentially, it's a set of genes on this chromosome number 6 that code for proteins that present antigens or encode how the immune system works. When we say you have a match, that means the match is the HLA genes. There are a lot of other genes that might be different from one individual, one donor to a recipient, but so long as you can match the HLA genes, we know that the chance of the grafted cells taking, i.e. less graft rejection, is much higher, and the chance of graft versus host disease is much lower. If you have a mismatch in any of the HLA genes, those 10 crucial HLA genes, we know that the chance of graft rejection is much higher, and the chance of catastrophic graft versus host disease is much higher as well. So essentially how this works, HLA presents antigens or proteins to immune cells called T cells. Those T cells are the functional part of your immune system that go around your body and help prevent viral infections and other things normally. What we know is that they also mediate the ability of the immune system to recognize damaged versus healthy host cells. And in the case of hematopoietic diseases like myelodysplastic syndrome or AML in this figure, we know that these T cells are the crucial part of how the donor immune cells recognize and help destroy any abnormal of these leukemic or cancerous donor or recipient cells. Unfortunately, the counter to this is that those T cells can also recognize the recipient's normal tissues and accidentally think that there's something that they need to attack or destroy and cause inflammation in those tissues. And that's what we call graft versus host disease. So unfortunately, these same cells, the T cells, these new immune cells from the donor, mediate both this graft versus leukemia effect that we think is crucial to how stem cell transplants cure people. And they also mediate graft versus host disease. They're two sides of the same coin. We really think that the graft versus leukemia effect is how transplants cure people. It's not all the chemotherapy or other treatments they get. It's truly an immune response from the donor cells against the recipient's residual abnormal MDS or leukemic cells. As I mentioned, a full match between a donor and a recipient now is considered 10 out of 10 for all the 10 crucial HLA genes. Since we started having successful transplants in the 1970s, the number of transplants has increased dramatically. You can see in blue the allogeneic transplants that we're focused on today. Those are the ones where you have another healthy donor giving cells to a recipient patient. Autologous, again, is when the patient receives his or her own cells back after isolation. The bone marrow donors worldwide, or what we call the WMDA, is a registry of donors worldwide that allows us to match people, donors with recipients. So if anyone can volunteer to be a donor. If they have an HLA match with a patient, then they can be that donor for that patient. Once that was founded in the late 1980s, the number of transplants really took off. Just because we were late, that really enabled us to find more donors for recipients. You can see the number of autologous transplants also increased from there. And then there's this interesting dip. They used to do autologous transplants for breast cancer patients, actually. But in the late 1990s, this was found to not be effective, and actually the risks outweighed the benefits. And so that really dropped off after that point. So who can be a donor for an allogeneic stem cell transplant? Historically, we really preferred match-related donors. So the chance that a sibling of yours, a blood sibling from the same parents, has a 10 out of 10 HLA match for you is about 25%. There's a 50% chance they're half match, and a 25% that they inherited none of the same HLA genes from your parents. So not everyone has a matched sibling. So that prompted us trying to find other sources. As I mentioned, there's this incredible registry now. In the US, we call it the National Marrow Donor Program, but it works closely with the World Marrow Donor Association, WMDA. So there's a pretty good chance that you can find an unrelated person who has a match for you. So matched unrelated donor or MUD transplant is quite common. And now we've started even using some mismatches. So mismatched unrelated donor or MMUD is also an option. Additionally, you can isolate hematopoietic stem cells from the umbilical cord after a baby is born. The baby is not affected whatsoever. This is usually tissue that's discarded. But the amount of stem cells you can get from an umbilical cord after a baby is born is small compared to an adult healthy donor. But we still use umbilical cords as a source of stem cells in some cases. Nowadays, we actually can do what's called haplo or half-matched transplants. The benefit of this is that you have a much higher chance of having a half-matched relative. So a 50% chance that your sibling is a half match. Any of your children and your parents are by definition half matches for you. There's certain medications that help prevent the graft versus host disease that would be catastrophic with a half match that we now use, and haplo transplants now have similar outcomes to full match unrelated donor transplants. So it's an incredible resource for people who don't have a sibling or who unfortunately don't have a unrelated match. And then I'll mention one other thing. There's something called a haplocord transplant, in which we use a haplodonor combined with a cord donor, and we kind of get the benefit of the adult donor in addition to the benefits of the cord transplant. It's kind of a hybrid, and it's something that we do in some cases if we have both options. So in terms of numbers, nationally, at least in the US, you can see that the match-related donor transplants were the earliest and definitely preferred. But now as we get into the 2000s, matched unrelated donors and haplo transplants are increasing in number just because it's a lot easier to find a half match or an unrelated donor than it used to be. Cord blood and mismatch unrelated donors are an option if you don't have any of the other three major ones. I mentioned the NMDP and WMDP. These are the donor programs where you can find an unrelated donor. You can see there's over 40 million donors worldwide, both adult and cord blood units. So what is the chance that you find a match in these 40 million potential donors? Unfortunately, there is a lot of diversity here. If you're and this is a lot based for historical reasons and sort of socioeconomic and demographic reasons as well. Very complex picture. But long story short, if you are a white European descent, you have over a 70% chance of finding a donor. And unfortunately, some, especially South American or Caribbean populations, the chance is much less than 20% that you find a suitable donor. So I just present this to encourage everyone to really, if you're willing, sign up. We really need donors for everyone that comes. We'd like to be able to offer a transplant to everyone, regardless of their background. So what is a typical transplant course? So if you're a newly diagnosed patient, The first steps that happen is you get some pre-transplant treatment to help knock down your abnormal cell population. This is kind of to get the disease under control so that you're in the fittest possible situation going into the transplant. After that treatment, you get some pre-transplant testing to make sure that the disease is knocked down and we achieve the effect we need so that you're in the best possible place going into the transplant. While this is happening, our team or any transplant team will be doing a donor search. So we'll be looking for siblings or doing a search of the registries to look for a suitable donor. Your transplant physician will go through the options if you have multiple and decide with you what is the best donor for you. After that, you undergo a conditioning regimen. This is intensive therapy that we give prior to the transplant to wipe out your old bone marrow system to make room for the new bone marrow system. The conditioning regimen also helps knock down the disease, but again, it's the transplant itself that is the curative therapy here. Once you get the conditioning regimen, what we call day 0 is the day you get the cells from the donor. This is a simple IV infusion. Often it's a non-event. It's an exciting day conceptually, but often patients don't even notice, they don't have any side effects. They don't feel any different. Really, it's the post-transplant period where the patient is most delicate in that their old immune system, blood system is on the way out, and the new immune system is still taking time to engraft. That's when you're most immunocompromised, so you stay in the hospital. You require a lot of infection prevention medicines, and you get immunosuppressive medicines to help prevent graft versus host disease. Sometimes your doctor may recommend some post-transplant therapies, again, to prevent infections and graft versus host disease, but also to help eradicate any leftover abnormal MDS or other leukemic cells. That's also an emerging field, what we call maintenance therapy. Is even though the transplant could cure people, we know that some people relapse. So we try to give therapies that are mild, well tolerated, but also might help prevent relapse. And that can go on for quite a while. After the transplant also, you will have additional disease monitoring. Usually that's bone marrow biopsies to check and make sure your disease is actually treated, that there's no abnormal cells detectable. So before the transplant, from the time of diagnosis to a transplant, the time period can vary, but the fastest we really can get a transplant arranged and organized is usually at best 2 months. Sometimes it can take up to 6 months, depending on the severity of the disease. That really shapes our timeline for how quickly we can get to a transplant or should get to a transplant. The post-transplant period, the first 3 months are the most delicate. Up to 6 months, you can still feel quite sick. Even a year, I tell my patients, don't expect to feel like your old self for up to a year. And post-transplant therapies, including maintenance therapy, can continue for up to 2 years. So it's a long process. It's a big investment, but we do it because it can cure people. So at least at the University of Colorado, where I work, we do about just under 100 transplants a year. We do this for a lot of different bone marrow diseases and other problems. The most common we do this for is AML. It's over 40% of patients that get transplants at our institution get it because of acute myeloid leukemia or AML. In terms of MDS and related myeloproliferative neoplasms or MPNs, that's these 4 categories here. That accounts for about 20% of our transplants. In terms of outcomes, if you look at by every 5-year increments starting in 2006, you can see that at least in the more recent years since 2020, that black line, our outcomes and overall relapse-free and overall survival have improved significantly from the early days. So we have made great improvements in the way we do transplants, and our outcomes are getting better and better each year. So an important consideration for transplants for myelodysplastic syndrome patients in particular is that MDS is a wide spectrum of diseases. There are very low risk MDS patients that may never need treatment and can live years without any problems. But then there's higher risk MDS, which we know can progress to leukemia very quickly and likely will cause major problems for the patient within a short time frame, weeks to months, years at best. So who do we decide to do a transplant for? I'll give you two scenarios. The first, an older patient with lower risk MDS. It's very clear that a transplant in that case would likely not provide benefit. The risks of the transplant could be a bigger threat to this patient's life than their MDS itself. However, a younger patient with higher risk disease that we know will cause problems soon, the risk of that MDS outweighs the risks of the transplant. And if you get the transplant in a young patient that cures them, then they can live the rest of their life, decades, without having to worry about that MDS anymore. So in that case, clinically, it makes sense to do the transplant. There are more ambiguous situations. So let's say a younger patient with lower risk MDS. It's kind of, definitely a gray area how likely it is that the MDS is going to cause problems. And does that outweigh the risks of a transplant? Very unclear. And that's when we talk to the patient. We kind of discuss the pros and cons of each choice, and we would support them whatever they may decide. If they decide to do a transplant earlier or later, or just wait and see, those are all options. So it gets it's really important to have shared decision making with the patient in those scenarios. Same with like a middle-aged patient with moderate risk disease. Again, a very, very gray area. So a lot of important discussions to be had. So why don't we do transplants for everyone? The big problem is the treatment-related mortality. That means just the transplant process itself. Can that kill you? Unfortunately, we know that even with modern medicine, all of the best practices that we have, all of our technologies and understanding of disease and transplant procedures, the risk of dying from just doing the transplant can still get up to like 25%. You can see that in this graph in the first 2 years post-transplant, the line really approaches 25%. And then long-term, those numbers can continue to accumulate, but patients typically in those situations might be dealing with other health issues, and so it's not directly related to the transplant itself. The major causes of treatment-related mortality that we worry about are infections post-transplant when the immune system is not functioning. The host immune system's knocked down, the donor immune system is still learning how to function in its new body. We've talked about graft versus host disease, so the donor cells attacking the normal tissue in the recipient. Complications due to anemia and low platelets in that early post-transplant period. So bleeding problems, anemia can cause all kinds of symptoms. And then, of course, graft failure if the donor cells do not take in the recipient. Now that we know all about HLA and how to match people appropriately, the chance of graft failure has gotten very low, but it's still a possibility. Ongoing clinical trials in transplants are really focused on reducing treatment-related mortality, so reducing graft versus host disease, and on the counter side, increasing the chance that the transplant cures you. Most of this research is not MDS specific, but any MDS patient undergoing transplant will benefit from these trials as well. Just to show you what we look at clinically, we use the NCCN guidelines typically in the United States. So we have guidelines for low risk MDS and higher risk MDS. And not to delve into the details too much here, but for lower risk disease, we typically try other treatments represented here in the middle. But then if we have disease progression or these treatments don't work, then at the end, you might still consider an allogeneic transplant for select patients. The algorithm for higher risk MDS is completely different. The first question you ask is, are they a transplant candidate? If they are a transplant candidate, it's very likely that you'll try to get them to a transplant quickly. So that's allogeneic transplants. We know that the graft versus leukemia effect of an allogeneic transplant, or the ability of the donor cells to kill leftover abnormal MDS cells, is how those transplants cure people. So knowing that, can we develop other cell therapies, other immune cell therapies that can do the same thing without the need for a full-blown transplant? One major cell therapy that's gained traction for a lot of diseases these days is called chimeric antigen receptor T cell therapy. It's already one of the best therapies that we have for other diseases like lymphoma and myeloma. Essentially, what you do is you collect the patient's own blood. You harvest those T cells that we know are the crucial immune cells for fighting abnormal or leukemic cells. You reprogram those T cells in the lab using genetic engineering to put on a receptor, here depicted in red, that allows them to attack the leftover cancer cells or MDS cells better. So again, this type of therapy is FDA approved for many hematopoietic disorders. And there's hundreds of trials ongoing. Unfortunately, in myeloid diseases like MDS, there's been some hurdles that we haven't totally overcome yet. First of all, we know that the abnormality that drives MDS and other myeloid diseases is actually at the stem cell level. So if you were to develop a CAR T cell that targeted stem cells, you'd essentially wipe out the entire blood and immune-forming stem cell compartment and therefore render someone without a functional bone marrow. And inevitably, then you'd have to do a transplant anyway. So that doesn't really help us. Really, what we want to do is find CAR T cell targets that allow the CAR T cells to attack only abnormal cells and not all stem cells in the recipient. So there are clinical trials ongoing, not many in MDS. I wanted to highlight one that was published in 2023. This group developed an NKG2D-based CAR T cell therapy. In their trial, they included relapsed refractory AML and MDS. But out of all the patients they tried it on, only one of their patients had MDS, the rest had AML. Unfortunately, we have observed this issue where some patients getting CAR T cell therapy actually develop myelodysplastic syndromes. This is because as part of the CAR T cell therapy, you have to give immunosuppressive medications that can cause abnormalities in the bone marrow compartment that allow any underlying MDS to emerge. So it's kind of, you don't want to create a therapy that can actually worsen the problem. So something that's to look out for in our CAR T designs for myeloid diseases. At the University of Colorado, we've been developing a CAR T cell that targets CD64, which is a protein that's commonly expressed on acute myeloid leukemia. This is a really new thing. We just had a poster presented in the last year at our large conference focused on hematopoietic diseases. And while we saw it worked in AML, it also has worked in high-risk MDS patients. So we expect an early phase clinical trial to come out later this year and be available at the University of Colorado using the CD64 CAR T cell in AML and high-risk MDS patients. So that's the main things I wanted to share with you today about allogeneic transplants, how we think about using them in MDS. Transplants are not for everyone. They can be curative, but they carry significant risk. Ongoing studies in transplant are focused on reducing relapse and improving safety. And cell therapies that sort of harness the ability of immune cells to fight abnormal myeloid cells are coming out. There's several hurdles to success, but I really expect some CAR T cell and other cell therapies to start to be available for MDS and other myeloid disease patients in the near future. Thanks for your time. That's all I have for today. I look forward to any further discussion afterwards.
Thank you so much, Dr. Kent. That was a wonderful presentation. Very excited to get to our question and answer segment. So for all of the participants on, if you could submit your questions through the Q&A portion, and we will take as many as we can in the time allotted. I'm going to switch off my video and just let Dr. Kent answer as we read him those questions. So the first one that we received is for sibling stem cell donors. What is the acceptable sibling age range?
Hi, everyone. That's a really good question. We typically don't accept minors, so anyone over 18. The younger, the better, but there's no strict upper limit. If anyone under 40, that's preferable. But over 40, if there are absolutely no other options, then we could consider donors over 40.
Great. The next one is talking about age for transplant. Can someone who is 78 years old qualify for transplant? For this person, their MDS was diagnosed 18 months ago. No other symptoms other than tiredness. Currently low risk. So a low risk category, 78-year-old.
That's a great question, Mike. Something to discuss with your MDS team. Again, there's no upper limit for transplants. We have transplanted people in their early 80s at our institution, but the older you get, the higher the morbidity and mortality associated with transplants. A lot of how we decide if someone's eligible for transplant is taking into account not just their age, but also their overall fitness, chronic health conditions, et cetera. So very healthy marathon running 78-year-old, I would say, could definitely be eligible for a transplant. So something to discuss with your team.
Great. The next question is, what is young? And I think this is in reference to the examples provided. That for the young patient with high risk, it might be a good option. So what would be young in that scenario?
Yeah, thanks, Katie, for that. Again, sort of have to temper that on life expectancy in general and overall health. There's more than just a strict number that we're looking for. We're making decisions about transplant or treatment options or donor eligibility and everything that really take into account all the patient factors involved.
Great. The next one talks a little bit about cellular therapy. So when do you think CAR T will be available for MDS?
Thanks, Junia. Yeah, I know there's been some trials early phase already. For instance, the one that I mentioned in the talk about CD64, we're hoping to open at our institution later this year. When will they be sort of FDA approved as standard of care? That remains to be seen. Unfortunately, the average clinical trial, even phase ones, can take several years to accrue enough patients and to follow those patients long enough to know how safe the treatment is before the FDA will consider approval. So it could be a few years yet, but I would say within the next 5-10 years is very reasonable that we would have a CAR T for MDS.
Great. How soon after a transplant will you know if it's success or failure?
Great question. So after a transplant, we always do a bone marrow on around day 28 and around day 80, and then after 1 year, at least at our institution. That's pretty standard across the board. If each of those bone marrows shows no evidence of disease, we feel really good that the transplant has worked. Even the early day 28 marrow, if there's absolutely nothing detectable there, that's very reassuring. Unfortunately, there's no guarantees. So people with negative bone marrows, even after a year, can still relapse after another year, 2 years, even up to, I've seen late relapses up to 6 years. That is very rare. And there's a reason we don't keep doing bone marrows indefinitely. We think that doing a bone marrow after 1 year, if that's negative, we feel quite confident that that it's worked per se. But yeah, unfortunately in medicine, there's just no guarantees.
Got it. The next one is for SCT treatment relapse mortality or treatment TRM, I'll leave it at that, and the relapse rates,
Yep.
are they better for younger patients and if they're otherwise healthy?
So definitely younger, healthier patients have less treatment-related or transplant-related mortality. So they can get through the process of the transplant with fewer complications. Relapse rates also tend to be better. That's usually because you can give a stronger conditioning regimen prior to the transplant, which really helps wipe out a lot of the abnormal cells before you give the transplant. Older patients where you have to use reduced intensity conditioning, that can affect the relapse rates. So yes, in general, your question, to answer your question, yes, on both counts.
Perfect. So for the next one, it's not necessarily transplant related, but if you have any insight that you could share for the newest medical treatment for MDS with ring sideroblast outside of luspatercept and Vitello.
I mean, those are really some of our newest ones that are FDA approved. There's several other clinical trials going on with different drugs. Um, so unfortunately, that's kind of where we're at with FDA approved medicines. There are many other approved drugs, older drugs that we can use in ring sideroblast disease. Nothing specific about them in particular. So those are not the only two options, but nothing really newer that's currently FDA approved right now.
Great. I will say if you're interested, I know you mentioned clinical trials. If you're on the webinar and you're interested, let us know. We do have a database. We can try to help you find something.
Yep. Yeah, there are so many clinical trials going on with cell therapies, other disease modifying agents. Um, so definitely, if you have tried all FDA approved therapies, it's not that you're out of options. You just have to really explore the clinical trial space.
Yes. Um, Next question comes from 75-year-old male with low risk MDS, wanting to know what is the overall survival rate after transplant?
Well, first of all, a 75-year-old with low risk MDS, they may not need to get a transplant. They may live long enough without even any kind of therapy, um, and thus not need to take the risk of going through a transplant. Um, if their disease were to progress and we were to consider a transplant, there are so many factors that would go into determining prognosis that I wouldn't feel confident answering that question to a specific degree without knowing more about the specific case.
Perfect. Um, if you want to speak a little bit about maybe the comorbidity index and what goes into that, I know we've had questions too, like if I've had a previous heart attack, can I not get a transplant? So I know that kind of goes into that decision as well.
Yeah, I mean, there are scoring systems, if you will, that give you a general idea of what the risks of a transplant might be versus the risk of not getting a transplant. We kind of compare those two risk scores against each other, like the risk of the transplant versus the risk of the MDS causing significant health issues. Um, the factors that go into these risk scores in terms of determining life expectancy and transplant related mortality, they give you an idea, but I never say based on a specific score from that index, I will make a specific decision for a patient. It just gives you more of a gestalt of what's going on with the patient. Every transplant doctor, every MDS doctor will have a different threshold for what they consider safe or not. So hopefully those are, if in those situations where it is ambiguous, if it's going to help or not, just really be sure you're having a thorough discussion with your doctor about what are the pros and cons that they're weighing. So kind of a vague answer, but that's why when I see a new patient, and we're talking about a transplant, we spend at least an hour talking about everything that's going on in their life, what their priorities are, about talking about their health and everything, because it's a big decision and there's not always one answer.
Yeah, that's a great point. Reminds me from like my nursing school days when they say treat the patient, not the monitor or the machine, right?
Right.
Like it's
Right.
different.
Yep.
Um, Another question that we received, so we get this one actually a lot, is an identical
Hmm.
twin brother a good candidate or just an identical twin in general?
That's a great question. And it really boils down to the biology behind it. So I mentioned the graft versus leukemic effect that helps cure people with transplants when you're treating an MDS or an AML. Um, the graft versus leukemic defect is dependent on genetic differences between the donor and the recipient. So if you have an identical twin brother with the exact same genetics as you would definitely have a lower graft versus leukemic effect. Those cells would not be different enough that the new immune system would be able to recognize and destroy them. So in general, I would not recommend an identical, like fraternal twin as a donor for a situation where I'm considering an allogeneic transplant.
Got it. So the next one is around, which is it's another question we get often around TP53, high risk MDS and transplant. So one of our participants wrote in that their brother is in this situation right now, otherwise
Mhm.
healthy, and wanting to know what are the anticipated challenges and concerns for matching and post-transplant with that TP53 mutation.
So yeah, two questions here. In terms of matching, depends on the HLA makeup. As I mentioned, people of European descent, fortunate for them, have a lot more donor options in the unrelated donor pool. I would definitely consider for a 52-year-old the cord blood options or haplo options. So it depends on your family tree and what all unrelated donor matches and cord matches you find. But I think just reading this brief blurb that I imagine they are able to find a suitable donor. Post-transplant concerns, there are many. I talked about them in the talk as well, but the biggest ones are in, uh, con conditioning related toxicities, infections post-transplant, graft versus host disease, relapse of the disease, unfortunately, depending on if the transplant worked or not. And those are the main ones. Oh, graft failure, although that's becoming less and less common as we are able to choose more suitable donors.
Got it.
Those are the big five things that I always talk to my patients about in terms of expectations post-transplant.
Okay. And then next person is 5 years past transplant, so congrats to you for sure.
Yeah,
Blood
congrats.
numbers, yeah, blood numbers looking good. They want to know what they should expect going forward now and how can they monitor their health.
5 years, I would feel really good if everything's looking good. There would be no indication to repeat a bone marrow biopsy at that time, unless your blood counts were to change suddenly. But 5 years post-transplant, the chance of relapse, if you're doing well at that stage, is exceedingly rare. So I would feel really good in your shoes, and I would just focus on living basically a normal life and enjoying yourself.
Great. The next one is a question we do get frequently. So, for this person, they had CAR T and they did go on to develop MDS with a single cytopenia, stable but high risk, and in watch and wait. So, for people in that situation who have already had CAR T, is transplant still an option or a future CAR T since they've kind of been through that?
The answer is yes. You can definitely get a transplant if you had prior CAR T. The transplant would wipe out all the immune cells, including the CAR T cells. So it'd be a total reset there. In terms of CAR T for the MDS, again, they're still in development, but there's no reason to think that you couldn't engineer CAR T cell therapy from the cells that are present, the T cells that are present. That being said, the health of those T cells does takes a toll after a while if you've been through several rounds of treatments for different things. I would, unfortunately, we don't have a CAR T cell approved. But if you undergo multiple rounds of different types of chemotherapies and things, engineering an effective CAR T cell at that point gets a little more challenging.
Got it. Um, Next person says in Europe, they do something like cytokine genetic therapy. Is this something that can be added to treatment here for MDS?
I'm not entirely sure what the cytokine genetic therapy is. We definitely don't do something like that in the United States. But if whoever this question came from, if you want to reach out and provide a little more information, definitely happy to look into that.
Great. The next one is, what is the relapse rate after transplant? I guess just a general number. I
Yeah,
know it's
that's
per
it's
person.
extremely variable. For low risk MDS in remission, who someone younger who undergoes a myeloablative transplant, the relapse risk is low. For people like an older patient who undergoes a non-myeloablative transplant, who has very high risk disease and like complex cytogenetics or TP53 mutations, then the relapse risk can be a lot higher. So unfortunately, I don't want to give one number that really doesn't do justice to the complexities of the disease itself.
Right. The next one is a really good question. So with transplant, there come a lot of restrictions on activity and
Hmm.
what you can do with sports, gardening, even driving.
Hmm.
How long does that last, I
Yeah,
guess?
that's a good question. Generally, if you've engrafted and you're not on significant immunosuppressive therapy, either for graft versus host disease treatment or other, just prophylaxis post-transplant, if you're not on those medicines and you're engrafted well, then I tell my patients they can live a pretty normal life. I have some patients go back to work after 3 months, although typically it's longer than that. Um, so it depends on the patient. If things go well, then 3, 6 months post-transplant, you should be able to live a pretty normal life.
Perfect. So the next one is talking about SCT, or the possibility of cellular therapy for treating symptoms. The question comes from a low risk patient diagnosed in 2020, watch and wait, but they're wanting to know about symptoms like anemia, infection, low platelets, I guess the symptoms alone.
Yeah, that's a great question. In short, a transplant will give you a whole new blood and immune system. So you should not have persistent anemia or thrombocytopenia after the transplant. It takes a while for that to happen. So, 3, 6 months in, you can still have cytopenias. So it's not an easy fix for those things. But certainly if you've tried everything else and you talk to your doctor, you can have a discussion, say, my life is significantly impacted by these cytopenias, and I understand the risks of the transplant. I'd rather do that now and hopefully get rid of these symptoms so I can live a better life. I would consider a transplant in a patient that had that rationale.
Got it. The next one is tell me about venetoclax. So I don't know if it means like
Oh.
specifically in the transplant world or getting ready to
Yeah.
go to transplant.
Yeah, it's approved for treatment of AML. We use it when paired with azacitidine, venetoclax and azacitidine combination is very effective for getting people into remissions. At our institution, we do use it in high risk MDS patients, kind of off label, because we know those high risk MDS patients biologically are very similar to AML patients. So I don't know if hopefully it will be officially approved. There is a phase 3 trial going on that we should have the results for later this year, exactly looking at that. But regardless, I think it is something that a lot of doctors will try in combination with azacitidine in the right circumstances.
Great. And we will definitely, as a foundation, we're on the edge of our seats waiting on that trial. So when the
Yeah.
results come out,
Yeah.
we will definitely let everyone know.
Yeah.
The next one is so graft failure. We know it's
Uh,
not as common, but what is done if that should happen?
If you have graft failure, it happens sometimes, but is extremely rare. I personally have not had a patient with graft failure, but if it happens, you essentially have to give another transplant right away. Um, Without another transplant, without an immune blood system that's working, the graft not working, you essentially would have catastrophic anemia and no immune system. So yeah, you just essentially do a second transplant right away. That can be sometimes from the same donor, or from a different donor entirely. We always have a backup donor ready, just to be extra safe. But again, that's very rare these days.
Got it. Along the same lines, can you speak a little bit about, I get quite a few questions about DLIs, the donor lymphocyte infusions, and their role
Hmm.
kind of after transplant.
So I mentioned this in the talk, but it's really we think the T cells in the donor that recognize leftover abnormal MDS or AML cells. And that immune response from the T cells helps kill any leftover abnormal cells. So donor lymphocyte infusion, lymphocytes, it's another name for T cells. The idea is that you're boosting that anti MDS or AML response in using just infusing more T cells. So boosting the graft versus leukemic effect. So anytime after transplant, if it looks like if there's any sign of residual abnormal cells, that can be either due to mixed chimerism, so detection of myeloid cells from the host still, or any subtle signs of relapse or persistence of the MDS through genetic testing or what have you. One could consider a donor lymphocyte infusion in that circumstance. Success rates vary a lot. I would say in florid relapse, if the disease is coming back with a vengeance, then a donor lymphocyte infusion will probably not work. You have to undergo additional chemotherapy or other treatment to get that back under control. But in people with low risk evidence of relapse, it can be effective.
Perfect. The next one they have questions about treosulfan. I'm not sure the exact question,
Y-
but
Yeah, I don't know what the question there is either. It's treosulfan's a drug that we use sometimes as part of the conditioning regimen for transplant. Um,
yeah,
I'm not sure what the specific question is about it.
yeah, definitely. If you're on the webinar still and want to email or put more information, we can come back to it. The next one is can you talk about the difference between a regular transplant and reduced intensity transplant?
Yes. So we have to treat people with the conditioning regimen prior to infusion of the donor cells. That conditioning regimen helps wipe out the old blood and immune system, makes room for the new blood and immune system, and also helps kill a lot of the abnormal cells there. So we have different intensities of the conditioning regimen. They fall into three general categories. Myeloablative, which means really strong, that's the strongest category, wipes out everything. Reduced intensity is better tolerated, so it's a little gentler, but it still can wipe out the vast majority of the old blood and immune system. And then there's something called the lower or the gentlest form of a transplant is non-myeloablative conditioning. Um, Non-myeloablative, by definition, should not kill every single leftover original, host immune cell. But it does a good enough job that allows the new donor cells to go in and help clean things up. So that's kind of what we're referring to when we talk about myeloablative, reduced intensity, or non-myeloablative transplants.
Great. This is a question not related specifically to transplant, so we can answer offline if preferable, but they're wanting
Mhm.
to know if you can combine drugs like Rytelo and Procrit. I've had the same question before about
Yeah.
luspatercept and
I
Procrit.
think, yeah, I think you can. Usually you want to try one agent or another, but I don't think there's any harmful interactions of trying both together. I've never had to. If one or the other doesn't work on its own, then we kind of move towards other drugs, uh, like like an HMA or azacitidine, what have you. So I personally haven't tried it together, but I don't think I don't think a doctor wouldn't be able to try that in a certain circumstance if they really wanted to. Um, yeah. Sorry. I don't
No, no, no,
I
you're
haven't ever had a circumstance where I thought that was the best option.
yeah. I do think there are some clinical trials like trying to look at it and see if it might be
Hmm.
preferable. But so the next one is one that we may or may not be able to answer just because every patient is unique and you may not have quite enough information. But low risk treated with Vidasa 77, otherwise pretty good condition. So I guess the question here would be what happens after Vidasa in that low risk group, since, transplant may
Yeah.
not be the best.
Yeah, that's hard for me to answer. If it's not working in the sense of it's not reducing the blast counts or it's not improving cytopenias, then my next choices would differ. But if I were in those shoes and the conventional therapies were potentially not having the right effect, I would definitely talk to my doctor about what clinical trials they could offer.
Yeah. The next one kind of follows up on that. It says, how do I
Yeah.
register for a clinical trial?
Yeah, so that's a great
Yeah.
question. It seems nebulous, I imagine, but essentially your doctor has to enroll you. Um, every hospital that does clinical trials has a clinical trials team. They help with making sure the patient qualifies based on the specific inclusion or exclusion criteria for each trial. And then there's a lot of processing that goes on, sort of paperwork behind the scenes. So it's not like you can just go on a website and sign up. What you can do though is ask your doctor about a specific trial. If they don't have it open at their hospital, then have them help you look for a place that does have a certain trial open, if that's what you're looking for. So in those circumstances, me as a physician, if we don't have a trial open at our institution for a specific patient, I will ask around to all the colleagues I know around the country saying, I have this kind of patient. Is there something that you might be able to offer to them? If they say yes, then we make a referral and have that patient seen at that hospital. Does that make sense? I hope.
Yeah, yeah, that's absolutely great. Also, from a foundation standpoint, we do have a portal that you can join and put in some basic information. So, like, kind of where your accounts are, your subtype, and whatnot. It will connect you with a person you can speak with, or you can also get a list of potential clinical trials. So, if you're wanting to do a more broad, kind of just bigger search, we can do that as well. So,
That's
just let
great. That's a great resource.
yeah,
Yeah,
it helps versus clinicaltrials.gov lists all trials, but it's hard to navigate. So
yeah, yeah.
trying to
And
help
if
there.
you find a trial, you still have to see a doctor and go through the
Right.
screening process. So unfortunately, there's no guarantees. You have to be evaluated thoroughly by the clinician involved in the trial.
Yeah, great point. So this another question is there a possibility that gene splicing may be a future consideration?
I think that's referring to literally genetic manipulation of, let's say, the mutated cells. There are other diseases where, for instance, like CRISPR technology is being used to edit abnormal genes in cells. Um, that technology is very exciting to consider. It's pretty hard to do in real life, but I don't want to say it's impossible. I think technologically, there's still a lot of barriers to that being a clinical option in the near future, but maybe 20 years from now, that's definitely something that could be done.
Great. Um, Next question, and I think it applies to both CAR T and transplant, is are there specific chromosomal abnormalities, deletions, mutations, and whatnot that may make it more or less effective?
Yeah, it's definitely possible. I don't think that's been well studied yet. Success of a CAR T cell therapy currently is dependent on expression of the target of the CAR T cell being expressed on the MDS. So, for instance, using the example of CD64, it may be that certain types of MDS with certain mutations have higher levels of the CD64 target than others. But we really haven't looked at enough patients yet to help guide that decision making. Certainly, as CAR T cells trials are undergoing, we may find sort of discrepancies, but as far as I know, there's not a lot of literature on that just yet.
Got it. The next question is there a reason someone would go with a haplo over a fully matched donor?
Um, it's the outcomes of haplo transplants and matched donor. I presume you're talking about a matched unrelated donor as opposed to a matched sibling donor. Outcomes these days between actually all three of those transplants is pretty similar. So a lot of the time we will just be deciding based on what's most convenient or fits within the time frame that we need to have the transplant done. Haplo, if it's like a sibling that lives next door to you, then getting that arranged quickly is just really convenient. If it's an unrelated donor who lives in Germany and is hard to, coordinate with, and that can be a barrier. Um, and then features of the donor themselves, if the haplo donor is healthier and younger than your matched donor option, then that would be a factor as well. So right now, I think a lot of it really would depend on what the options look like and a lot of different factors.
Really good points. The next one is about your clinical trial. So they want to know if your CD64 CAR T trial will be available at other MDS centers. Are you planning to expand beyond Colorado?
Great question. We're trying to just get it open at our institution currently, but certainly if the early phase of the trial is really promising, I can definitely imagine it would expand beyond our center. Um, you know, every trial is the results are more reliable or trustworthy if you do them at multiple sites. You just trust that in a real world situation that the success of the CAR T wouldn't depend on it being done at one institution. You would hope that it would be effective no matter where you do it. So our goal is always to expand the trials as much as possible. That being said, there's a lot of factors that go into whether or not a trial can be opened at other sites, budgetary constraints, all kinds of logistical challenges. So no guarantees yet. Currently, the trial is aimed to just open at University of Colorado.
Got it. Next comes from one of our participants, says they have CLL and MDS and are being prepped for a BMT at City of Hope. Their
Mhm.
question relates to family members as donors. They have one sibling willing to donate. How distant, so for say they live in Europe, can a potential family member be?
Well, I've definitely screened some cousins before, but just looking statistically, what is the chance that someone further separated from you genetically on your family tree would be a match? So there's a 50% chance that a sibling is a half match for you, a 25% chance they're a full match. 25% chance that they're not a match at all. That's a sibling. So imagine divide that by two by each degree of separation in your family tree. If it's a distant cousin, then statistically the chances are get much lower that they're going to be a match for you at all.
Got
But
it.
it's not impossible. So I would just speak with your doctor about what your options are as they come in. More likely, it's that you would just choose a haplo transplant or a matched unrelated donor as opposed to screening like third cousins.
Okay. What about physical distance? Can they be
Mm.
anywhere globally?
Yeah, physical distance in terms of can you screen them? That really doesn't factor in at least at our institution. Our screening kits we just mail out. We can mail them anywhere in the world. We do typically prefer that a relative donor, so like as opposed to match unrelated donor, that relative we prefer that they come to Colorado to actually donate their cells to do the transplant. But it's not impossible to have them go to a institution in Europe, have their cells collected and frozen, and then sort of mailed across the Atlantic to do the transplant. So yeah, I would say physical, if you have the best donor and they are somewhere else in the world, the physical distance should not be why you do or do not choose that patient or that donor, excuse me.
Perfect. The next one they're wanting to know about the chemo preparation. So would you consider Cytoxan, if used in the prep to be intense?
Uh,
It's a
sorry, I'm not
two-part
seeing
question
that
on there.
question, but yeah, cytosine chemo intense
Yeah, underneath, I
preparation.
think they
Oh
meant
yeah. Okay.
to put
So
Cytoxan. Yeah, yeah.
So yeah, there's a lot of different drugs that you can use and radiation. Any of those drugs on their own, if given at a high enough dose, could cause myeloablation in a patient. The idea is you combine the drugs and or radiation together at lower doses to have the same effect but mitigate toxicities. So just a drug on its own, you can't say if it's more intense or less intense. It's all about the dosing and the combination.
Perfect. Next one comes from someone diagnosed with MDS, 2% blast in the marrow. So two-part question. So the first one is, what is your experience in the rate of disease progression, in
Mhm.
terms of percentages to AML? And then have any TP53 thoughts? I know there's a lot of
Yeah,
information going on right now about like variant allele frequency. And so if they're having a high
sure.
expression of that, what does that mean exactly?
Yeah, so 2% blasts, the lower the blast count, typically the better. So less than 5% is good. If you had 18% blasts, it's very possible that would progress to AML within a matter of weeks to months. Um, but unfortunately, TP53 can be a bad actor and it does portend more rapid progression to AML, compared to other mutations that can be drivers in MDS. So I think according to the IPSS-M score, there's a calculator online that a lot of physicians use. You can find it yourself. It's free to use. You can put in the numbers and it will give you an actual percentage. Um, so the other things beside blast count, cytopenias, other mutations that might be there, the karyotype and or cytogenetic abnormalities, all those factor into that calculator. And it'll give you a number, like percent chance of progression to AML within a certain time frame. So maybe without all the information, I can't say exactly what that number would be for you. It may be worth talking to your physician, to your clinician about that, or trying to use the calculator yourself. That's probably the most precise way to predict everything.
Got it. All right. I think we've already answered the question on CAR T therapy and low risk MDS for symptoms. Um, and then I have a couple questions from prior, to when we asked questions if they had for them to submit them prior to registration.
Sure. Yeah.
So one of them, can you explain the difference in like blood typing and HLA? Because they're not the same, right? So you hear type,
Yeah.
but
Yeah,
they're
that's
different.
we get that question a lot. So HLA genes are very different from the genes that cause your blood type. So the genes that cause like the A, B, and then the um, Rh positivity, that's typically part of blood type. Those are distinct genes, and they are not linked to the HLA. So you can have a blood type match with someone, but not an HLA match. Just think of them as separate things. They're separate genetics.
Got it. Right. Someone wants to know also if there are targeted genetic therapies for patients right now.
So the one that's approved, if you have an IDH mutated type of MDS, then ivosidenib and olutasidenib are approved for that. Those are drugs that specifically target the IDH1 mutation. Um, there are other targeted therapies that we use in AML, that I imagine are being tested in MDS that shares similar genetic features. Those aren't FDA approved yet, but I imagine they might be at some point, either in combination or as monotherapies.
Great. One question that we get often is if conditioning kind of wipes out everything, right, and gives you that clean slate, why
Mhm.
do you then need treatment prior to transplant to get the disease under better control? Um, like
Uh,
treatment prior to conditioning, if conditioning just is going to wipe everything out.
yeah, that's a good question. So we know that if your disease is in a better remission prior to even the conditioning, that you have a better chance of cure. The conditioning wipes out all of your normal cells and a lot of the abnormal cells, but not everything. It's really that immune response from the donor cells going into the body and finding any leftover cells, and killing them. That's what cures people. If you have rampant disease. So tons of abnormal cells floating around in your bloodstream or in your body. The conditioning wouldn't clear all of them, and the immune response wouldn't be able to clear all of them either. So that's why we think the chance of relapse is higher if you don't get the disease under control even before the conditioning happens.
Got it.
It's like a statistical game, it's like a numbers
Yeah,
game.
yeah, yeah. The next one is from, we have someone who's a pretty serious cyclist, so trying to stay in shape, but I think struggling with anemia, fatigue due to the
Mm-hmm.
MDS that carries on into like if you were to get transplant. So do you have suggestions on ways to kind of combat that?
I mean, it's great that you're in great shape. That's going to help you no matter what treatments you undergo, including a transplant. Um, if the anemia is the cause of shortness of breath, fatigue, then depending on what your doctor's already tried, then you could try erythropoietic agents that help support production of red blood cells, like Neupogen or Aranesp. But if those medicines are not working, and you've tried hypomethylating agents, then consideration of a transplant could be possible, knowing that you would be kind of down and out for a while before you'd fully recover. That doesn't mean you couldn't get back to cycling after a transplant as well. So lots of things to consider. In that case, definitely would defer to your physician to make those kind of decisions based on the limited information provided.
Got it. We have a question that came in from a young patient with excess blast 1, severely low hemoglobin platelets, neutrophils, scheduled for a transplant in 6 weeks. They're wanting to know if they have fibrosis in their marrow. How does that factor in? I know that's a new
Um,
category.
Yeah, so bone marrow fibrosis, if it's really significant, can affect the rate at which donor cells are able to engraft in the bone marrow and does slightly increase the risk of graft failure. In patients that have high fibrosis in their bone marrow, typically I skew away from cord blood transplants because they really have a hard time engrafting. But other types of transplants, maybe it'll just take longer, and that there's a slight increase in the risk of graft failure, but it should still be doable. I typically don't say someone's not a candidate if they have fibrosis. I'd still try to proceed.
Great. Just a quick reminder, we are getting close to the end of our Q&A session, so do submit any last minute questions that you might have. So someone's asking if you can speak a little bit about specific mutations. So they ask about RUNX1, SRS, F2.
Yeah, I mean, there are maybe 50 or so mutations we know that can cause MDS. Some of them have distinct phenotypes. Some of them do not, but may affect the rate of progression to AML. So I encourage everyone to check out the IPSS-M calculator if you're curious about what the specific mutations you have are predicted to do in terms of affecting the behavior of your disease. That's probably the best way to figure that out.
Perfect. I get this question a lot. At what point on the MDS treatment journey should you consider HLA testing? Is it ever too soon to get the ball rolling on that?
Yeah, in my opinion, I don't think it's ever too soon. It's not a huge deal to just get it done. The reason for anyone I would consider it, if you're at all considering a transplant, while we statistically try to predict how fast someone might progress to AML, each patient's different. So at least getting that hurdle out of the way. If you were ever to need a transplant, then that would help move things along more quickly. If you never need a transplant, no big deal. If you're not ever considering a transplant, let's say you're older with low risk disease and don't want to do a transplant or aren't a candidate, then that's basically the only circumstance where I wouldn't do it at all. Yeah, in our institution, if the transplant's on the table, might as well get it out of the way.
Got it. So the next one's an interesting question about ring sideroblast. It says, does diet help mitigate the iron on the ring sideroblast? We've heard kind of both things, so it's interesting.
Yeah, so I'm not, this isn't my area of expertise. Katie, I apologize. I'm curious what you've heard. There are some suggestions that certain vitamins can help reduce or help anemia in those circumstances. But I apologize. I'm not really well versed in the literature on that.
No worries. I think that there's confusion because the iron that you see on the ring sideroblast is different than the circulating iron.
Hmm,
And that's kind of the questions that come in with that.
I see. I'll have to read more about that. That's not something I deal with regularly as a
Gotcha.
transplant focused physician.
The next one's a great question. So is it still the HLA testing that you would need for CAR T, or do they test it differently?
Great question. Actually, for CAR T cell therapy, those CAR T cells are engineered from your own T cells. So you do not have to do HLA testing because the HLA is the same if you're using your own cells.
Perfect. So the next question's about watch and wait, right? So
Mhm.
I get a lot of patients who call it watch and worry because it's just a tough
Yeah.
time.
Yeah,
Um,
it's a lot hanging
so
over your head for sure. Yep.
yeah, with all the trials that are out there and treatments, can you explain why watching and waiting can still make sense?
Really, watching and waiting is about avoiding toxicity. So we always talk about do no harm in medicine. If we feel like the therapies we could provide are not going to help you feel better, and they aren't going to change the course of disease, then that's why we kind of watch and wait. Um, but yeah, I would have to know more about the specific context of your disease and why watching and waiting felt like the best option. Um, yeah,
Right.
hard to say without more details.
So this one is interesting. So if you're HLA-B27 with ankylosing spondylitis, want would you want that to be matched? I think the question here
Hmm.
is like, so that's autoimmune. Um, what
Yeah,
happens with
predisposes you to
autoimmune and
autoimmune.
transplant? You know?
Yeah. Yeah, that's a great question. So typically, while HLA, certainly HLAs have a higher association with certain autoimmune disorders, they aren't a guarantee. So just having like HLA-B27 does not guarantee you will develop ankylosing spondylitis. If your donor has HLA-B27, they we wouldn't choose someone with rampant autoimmune disease, but just because they have that HLA doesn't mean that it would perpetuate that autoimmune disease if transplanted. So the immune
Okay.
system, there's a lot of complexity around why HLAs are associated with certain autoimmune diseases. Um, I think if you were doing a transplant, much more likely that the reason for the transplant, like AML, is worth taking any risk in a slight increase in your autoimmune disease or for the autoimmune disease to come back. Um, so yeah,
Yeah.
no guarantee. There are certain autoimmune diseases that I know I've seen cured by transplant, even in people who have the same HLA. It's just total reset of the immune system.
Yeah. Very interesting. The
Yeah,
autoimmune connection for sure.
yeah, it's a very complex biology. Yeah, definitely something we think about though. Yeah.
Yeah. Um, Next question that we get sometimes is, can you explain what tests are drawn after transplant to determine like at what level the cells are, donor versus, self?
Yep. Yeah, there's lots of testing we do. So genetic testing, looking for persistence of whatever mutation was present in your disease prior to transplant. We of course do pathology to look at the cells under the microscope to see if there's any abnormalities that they can observe. Do flow cytometry, which looks at proteins on the cells to see if there's any atypical patterns or anything that looks like your prior MDS. Um, there's chimerism testing, which looks at specific parts of the DNA and tells you whether that those cells are from you or from the donor. So obviously you want 100% donor chimerisms post-transplant. Um, those are the main tests that we do. So
Perfect.
genetic, pathological, and then some advanced sort of phenotypic testing.
Got it. Um, and another question that we get often is graft versus host disease, like that prophylaxis that you stay on, is that forever or does that end at some point?
Great question. In patients who do not have graft versus host disease, you should not be on immunosuppressive drugs forever. At our institution, we stop some after 1 month, some after 3 months, and some we taper down to around the 6 month time point. With no GVHD, our patients are off of all GVHD prophylaxis after 6 months.
Good. Um, what we know is that with transplant, finding a caregiver can be very difficult. So, do you have any tips or suggestions on how to manage that? I know I've seen some people do rotating schedules. I just don't, any tips for the caregivers who might be on the call?
Yeah, I mean, caregiving is tough, really, caring for the patient, worrying about them, the disruption in your life, have to go to a lot of appointments. A lot of our patients have to go on disability and take a break from their jobs. Um, so it's a challenge. I don't know any way to share the burden with other support, friends, family, what have you. You got to just reach out to all your options. I don't have anything more specific than that, unfortunately. Everyone's sort of life and family circumstances are very different.
Yeah, no worries whatsoever. Do you have, and this may be the last question unless we get, well, maybe the second to last. So, do you have like a long-term survivorship program there or a long-term clinic that patients of transplant do follow up with?
We continue to see our patients, or at least offer to continue to see our patients annually for as long as they want. A lot of times, if they're feeling well several years after a transplant, they get tired of coming to appointments if we don't really do anything. We are always available, though, if something were to come up transplant related, to see them again. They're always our patient. So we are kind of our long-term survivorship clinic per se. In terms of support groups and other things, maybe you know better than I actually if there's resources available on the MDS Foundation website.
Yeah,
I think our staff does have some sort of paperwork on that, but I'm not super familiar with specifics.
yeah. We definitely do have some support groups. And right now we are definitely in need of support group leaders. So if you're interested in kind of stepping up and maybe that's something you want to do, message us after and then I can get you a list as well. Um, a question that I do get often is at what point do you repeat like childhood vaccines post
Hmm.
transplant and like why do you have to start over on the vaccine
Yeah,
series?
great question. So yeah, while you do get some T cells and some immunity from the donor, we don't assume that all of your immunity against all kinds of viruses is preserved. The stem cells that really recreate your whole blood and immune system, they don't carry immunity with them. So that's biologically why you have to just revaccinate to retrain your new immune system um, to to have immunity against all these viruses. We don't start revaccinating until 1 year post-transplant. I think there's going to be a change that we might give some transplants or some vaccines after 6 months, but currently we start at 1 year, and that schedule persists through, I think, the first year or two after the transplant. It takes a while to get it all taken care of.
Got it. So this is going to be, I think, our last question, and I'm sure I will get this many times over after this webinar, but
Sure.
are you accepting patients? And if so, is there
Yes.
a way to get them in the door? I know like we do send messages back and forth, but I'm sure I will get that question.
Yeah, all of our patients need to have a referral and then go through our intake team to make sure all the insurance and everything is taken care of. But I'm accepting patients. Any patient that's referred to us, I'm happy to see.
Great.
So I would talk to if you have an oncologist currently or a primary care doctor who's managing your MDS, what have you, feel free to request a referral. If it's written in the referral that you specifically want to see me, then our intake team will let me know. Um, yeah, I do not screen my patients. Anyone that wants to see me specifically, I'm happy to see.
Perfect. Thank you so much. Any last pieces of advice for the group before we sign off for today?
Um, I guess I would just say, there's tons of work going on in MDS and AML, tons of new therapies coming out. The rate of developments is accelerating. So really, it's never a good time to have these diseases, unfortunately. But we're constantly having new options for you. So if that's some sort of silver lining in all this, then we like to say that we are getting better at treating MDS.
Thank you so much. Thank you, Dr. Kent, for your time today and for the information you provided. This was phenomenal. Really, really great discussion. So, as Janice said earlier, this will be put online as well as the slides, so we will have access to that. If you have follow-up questions we didn't get to, feel free to message. I'm happy to reach out to Dr. Kent if it's something he can help us with, or if you're
Sure.
interested in a referral as well, we can try to help speed that process along. So definitely reach out. So I want to thank everyone for attending today. It was great attendance, and also want to thank our sponsors, so Taiho Oncology. So if anyone is on from them, we very much appreciate your support of this program. If that
Great.
is all from everyone, then we will sign off and have a great rest of your Saturday.
Yep. Thanks, everyone. Great questions.